So I'd like to thank all four presenters, Kate, Claire, Angela, and Yoa, for sharing their preliminary thoughts with us. We have about 15 minutes or so. I'm going to use the rest of our time together to answer some of your questions. So thanks for sending in those questions in the chat box. We're just going to start going through here. And the first question, which I think I'm going to ask Angela to get us started with this question, is how can we leverage the voices of the people we are working with and advocating for during COVID-19? How can we leverage the voices of the people we are working with, advocating for during COVID-19? And I think, Angela, if you want to get us started with a question, and then we'll go to Kate. Thank you.
Thanks, Sume. That's COVID is the great equalizer, because right now everybody is kind of at the same disadvantage, but we know that there are people that are even more disadvantaged. So when I think about that, it's about how can we work together to give the voice for those that are more, like, I don't want to say more disadvantaged, because I don't want to have, us trying to pick who's more disadvantaged. I think what we need to be doing is saying, okay, we can write letters, we can plan our policies, we can start to find ways to work across systems, which hasn't been done. We still want to silo health and education and government as separate systems, but in fact, they need to be working together. So I think that part of it is, can you raise the voice of the people that you work with? Yes. And I think that maybe it's about advocacy and how you first change your policies within your own organizations or communities, and then we feed that up in a way that everybody is included. That would be my thought to that.
Thanks, Angela. Kate?
So Alliance members, including community health centers and Aboriginal health access centers, have a bit of a leg up on this because of the way we all currently practice and are structured. So these frontline organizations are already community governed. They're run by and for communities. And so that means we can tap into those networks of staff, of peer workers, of board members, of volunteers in the community and clients to continue to give advice through the networks and structures that we already have to help make sure that we're making decisions that are reflective of what the community needs and wants and what their current circumstances are. So I think that that's really important, that where possible, if you have been able to structure in those things, you can rely on those now. I also happen to be a board member on a board of health. So I'm a member of the Toronto Board of Health and the board of the Association of Local Public Health Agencies here in Ontario. And I'm a citizen member, so that means I'm one of those regular people, not an elected city councillor, who's there to kind of help try to represent the voices of regular people. And so I'm using that role to kind of reach out on social media and in other ways to make sure that if there are things that aren't being covered by the organization, that I'm there to help be part of that voice of regular people. And certainly in our work, we do policy and communications hand in glove. And so that means again, as we're listening to people, we're also foregrounding those people. So right now, for example, we're trying to help get some media attention on the issue of agricultural workers and connecting reporters in southwestern Ontario, where there are so many of these workers who are arriving this week and next, with some of those workers, as well as the community health workers that work with them and the public health inspectors, so that all those voices are heard. So I think it's a matter of structuring it in, prioritizing it in your communications, and ensuring it's there in policy. And to be frank, we haven't seen a centering of equity in the responses. And so we use our responsibility at decision-making tables regionally and on the daily calls of the ministry's Emergency Operations Center and so on to ask questions on behalf of those people who don't have the privilege that we have of being at that table.
Thank you so much for that response, Kate. I'm going to ask if Claire and Yoav want to get in on that question. If you do, just speak up and we'll hear from you and we'll take a second question.
So I might jump in and then maybe we could start with Yoav on the next question. Can you hear me today?
Yes, we can.
Okay, great. So just a few really sort of practical points on that question, because that's a great question. And Kate and Angela, I love your answers. and I'll just try to build on them. So first of all, clear messages, okay, that are action-oriented and produce a solution, right, or bring a solution to the table. So watch the acronyms, watch our language, watch the words that we use that actually exclude and disadvantage some. So I think that would be one piece of advice on that. Number two, keep equity and the social determinants of health, the social instructional determinants of health, absolutely front and center in everything that we do. And one very practical tip would be to ritualize some of the questions that we ask. Like, for example, who will be affected by this decision? Who are we not thinking about right now? If we're not thinking about that particular population or community or that particular group, who might we access to get good, solid information about that population so that we can inform? So ritualize those questions as you make your decisions. Number three, sorry.
Sorry, I was just going to jump in, and say that we also need to remember that the 12 social determinants of health that are Health Canada's don't always reflect everybody, and that we have to remember that colonization and racism are also social determinants of health that we have to put forward.
Yeah, thank you so much for interrupting and putting that in there, Angela. So absolutely, I couldn't agree with you more. So thank you for that. I think Kate talked about using her networks or using the networks. So using the networks and structures that we have at hand, whatever those might be. And we have formal ones and we have informal ones to amplify the voice, amplify the perspective that we're bringing. And finally, this is a marathon, not a sprint. We're going to be in this for a while. So if you don't have success or feel, satisfied, keep going, keep trying. So that would be my answer to that question.
And, thank you all for that.
Yoav here. I wanted just to add one thing is also to echo the same sentiment of having the ability to speak in a language that is understood. A lot of the decision making that is taken by public health is supported by mathematical modeling and ideas related to that. We need to make sure that the information or the way that we come up with plans and decisions is communicated and explained, so it doesn't come as a dictation and another paternalistic approach, but it is understood by those affected. So we definitely need to have that in mind when we are talking about public health interventions that are put in place.
Great, thanks. And yours is just saying there that we need to make sure that the work we're doing, we're communicating that in a language which is understood. Thank you. So we'll take one last question, after which I'm going to ask our speakers to just close us off with some closing remarks. And so if we haven't gotten to your question, what we're going to do is after today's call, we're going to compile those questions and see if we can provide them some answers for you, or at the very least just share them back with you. So there's a question here which is around who were involved in the response. The question is, no, that's not it. Is anyone aware of rapid national data being collected related to substance use, alcohol consumption, and mental health episodes, which includes women who need to leave an abusive partner? So that is just a question on what are we collecting and where can we find it? Any thoughts there?
Well, I can tell you that David Fistman at the Lana School of Public Health has been doing quite a bit. He's an epidemiologist who's been doing quite a bit to show where we are and what our projections are. I'm not sure we have access to all of that data because of privacy laws and the like, but I know that some provinces are doing better than others in terms of collecting data, at least for their healthcare workers and who's infected. In terms of other populations, I'm not sure I've seen anything. I'll leave it there.
Great, thank you, Angela. Any others? Those of you who are in the data? Okay.
I think because of, it's Kate, I just want to say because of the rapid response, I don't think we have any nationwide data on this yet. But so the important thing right now is to be listening to those frontline workers who know exactly what they need and what their communities need. And we're hearing many people saying that we're probably about 2 weeks behind what needed to be done to do really good prevention amongst the populations that you describe here.
Great. Thank you, Kate. And I think that's a good way for us just to ask for some closing remarks. And I know that there's tons of questions coming in, and we'll continue to feed them in. So just given what we have heard from the four of you, and Kate, the point you're making that we're 2 weeks behind, but here we are right now. It's April 1st, 2020. Where do we go from here?
So you want me to start that off?
Yes, please, to close us off. So where do we go? For all of us on the line, where do we go from here?
So, listen, for all of you on the line, my strong feeling is that this is a marathon and a sprint. There are some emergency responses that we need to take collective responsibility for, particularly when it comes to personal protective equipment and supporting people to do the physical distancing that is necessary. We can't put out messages around physical distancing and then not allow people to follow through on that, whether they're living in overcrowded housing, whether they don't have any housing at all, and so on. And we can't be, today it was announced that here in Toronto anyway, that there would be additional powers of enforcement around those social distancing measures. And we know that when enforcement comes into play, and now they're going to be permitted to do carding again and requesting identification, that this enforcement is always disproportionately applied to racialized communities, Black communities, and Indigenous communities in particular. So there are some of those immediate responses that are really important, but it is also important for us to hang in there for the long term, and that means also taking care of our own mental health and well-being, and the best way to do that is to be in community. All of our research around social prescribing has really showed that the number one thing that can help improve your own self-reported health and well-being in a time of social isolation is helping somebody else. And so whatever it is that you can do and whatever it is that you can help support your communities to do is what's going to help you get through the longer term.
Great. Thank you, Kate. Claire?
I'm just going to say ditto to what Kate said there, and really thinking about how we build that social cohesion along with all of us practicing our physical distancing. And I couldn't agree with you more, Kate. Being in community, whatever that looks like, is really important to all of us on the way forward.
Claire? Yoav?
I agree with the fact of I have not seen any things like this in terms of the engagement of people trying to contribute and to participate, because being part of trying to help someone is critical in overcoming the pandemic. And I think we've already shown tremendous global leadership and connectivity, and I think we need to do that. And we have always the risk of closing borders and closing between provinces, and then leaving behind people who rely on the movement between provinces. So I encourage us to remember that we are still all in this together.
Thank you, Yoav. Angela?
It's April 1st, and I wish I could say COVID was a joke. But it's not. And I just keep thinking about Indigenous communities, specifically First Nations communities that are rural and remote, and they already face huge disadvantages, and Canadians don't often hear or see what's going on. We have boil advisories, so they can't use the water. They have inadequate housing. And when I say that, if you have 18 people in a 2-bedroom house, think of a 2-bedroom apartment in a city, that is far too many people to any kind of pandemic social isolation that we've been talking about. So we have to start looking at those voices, and there's going to be discomfort as we look at how do we change from here? What does this mean moving forward? So over the next 2 weeks, I'm hoping that people can self-reflect and start to think about how can we change our world for the better as this comes out the other end.
Thank you so much, Angela. That sounds like a great place for us all to sign off. How can we change our world for the better? I'd like to thank all our presenters for joining us today. I'd like to thank all of you for joining us on the line. We know that time is precious for all of us. We will be sharing a lot of the resources which have been shared today, as well as the responses you provided, because you all shared some really incredible examples of what you're seeing as policy windows here. And so it's great to see that there is this momentum for us to work together to really move forward in the COVID-19 response, but also in thinking about what our world looks like when this passes. Again, thank you all so much. We hope you'll join us next Friday, same place, same time, for our second conversation in the COVID-19 and Health Equity series. Take care, everyone.